Okay, the first thing is the premenstrual syndrome. Premenstrual syndrome is very, very important and very common in the young adults, like especially 16, 17, 18. A lot of these females present in the family physician practice, and you need to know all about the premenstrual syndrome, how you are going to counsel. And the first and foremost thing you have to rule out if this is a premenstrual syndrome or it is a premenstrual dysphoric syndrome. So we will discuss thoroughly what is premenstrual syndrome and what is premenstrual syndrome, premenstrual dysphoric syndrome. So, starting from the premenstrual syndrome, it is a physiological and emotional disturbance which is basically occurring at 1 to 2 weeks prior to menses. So, starting from the 1 to 2 week prior and lasts until few days. So it starts like 1 to 2 prior to menses, and then it goes along the few days until like after the onset of the menses, like starting from 2 to 3 days before and starting like up to like 2 or 3 days of the menses. So it will stay up to like that, and it includes like depression, irritability, tearfulness, like mood changes, and all of these things can be one, two, three. So all of these. It can also be called ovarian cycle syndrome because it is occurring during the ovarian cycle. Then menstrual melanoma, like having the moodiness, that's why it's called as like that. Then most of them, it is not completely understood. Then you can think of all the serotonin, dopamine, GABA, all these hormones are fluctuating, all of these neurotransmitters are fluctuating. So that's why the patient is having this, not actually patient, but the female is having this problem. Now moving on to the next one, the diagnostic criteria. So you need to know the diagnostic criteria because in the scenario, the words are written over there that that particular female having one affective and one somatic symptom. So one affective and one somatic. Now we need to know what is somatic and what is affective. So affective is having depression, irritability, angry, outbursts, all of those psychiatric conditions. This is called in this comes in affective. So there should be one affective and along with it one somatic. What are somatic? Having like breast tenderness, abdominal bloating, headache, swelling of the extremities, joint or the muscle, and the weight gain. So if you can see it, it doesn't have to be these somatic symptoms doesn't have to do with like human woman used uterus cycle. Like not, it should be like not involving the uterus, having pelvic pain. It should be, it could be anything like having headache, swelling. So it could come like that, and along with this, they will present that is primarily happening in the menstrual cycle. So one affective and one somatic should be there, like during the 5 day before menses in each of the three prior center. So they will definitely say that it has been happening from like past couple of like months, past couple of years, past couple of, so they will definitely tell you this kind of thing. So that's why you are going to see that this is a premenstrual syndrome. It is not like this is going to happen for the first time and she is coming to you. She will tell that she has headache from the last couple of months during this particular time, and she has been taking a lot of NSAIDs and it's not helping. So this is the particular scenario they will mention. On the basis of that, you are going to say that yeah, this is premenstrual syndrome and it is totally normal. So what you can do next about that? Then symptom relieved within 4 days of the onset of the menses. So she will definitely say by herself that even though she is taking an NSAID, the headache eventually doesn't go away, but after 4 days it goes away by itself. So this is what it is. So it does not reoccur until last least 15 days. So in this thing, you can also ask the female to make a menstrual diary. So on the menstrual diary, she note down all the symptoms, and then on the basis of that, you can see even it is premenstrual syndrome or she is mixing something from the premenstrual syndrome. So symptoms are usually in the absence of any pharmacological therapy. Should be like women should not be taking any medication, no hormonal injection, like no OCPs or anything. She should be taking and drug or the alcohol, because a drug and alcohol could be affecting this depression, angry outbursts. So there should be no drug use, no hormone, no pharmacological. If they didn't mention these kind of things, so you have to rule out these things first before making your diagnosis. So this thing also comes in your ruling out diagnosis. Then symptoms occur reproducibly during 2 cycles of the prospective recording. So when they are recording, making a menstrual diary, there should be at least 2 of the recordings that should mention that they have this symptom inconsecutively in their menstrual cycle. That on the basis of that, you will say, yeah, this is premenstrual syndrome. Otherwise, you cannot say this is a premenstrual syndrome. So you still have to rule out all of those other symptoms like having pharmacological, hormonal, drug, and alcohol. Just after that, you are going to label this as premenstrual syndrome. So patient occurs from the unidentified dysfunction in the social and occupational performance. Along with this, impact in the life is very, very important. This, whatever symptoms is happening to the female, it should be impacting. If it's not impacting, then she doesn't need anything. So now first line, on the basis of this impact, either you need to start hormonal contraceptives or SSRI. If it's not impacting, then you can just give exercise, CBT, and then vitamin B6, because she is having it at minimum level. So you can start from exercise, CBT, vitamin B6. But at the same time, if this is happening and impacting the daily life, like going to work, she cannot get up in the morning, having headaches and angry outbursts, so affecting their daily life. So on the basis of that, you can start the combined hormonal contraceptives, continuous or luteal cycle, low dose SSRIs. So you have to give these ones. So when are you going to give CHC and when are you going to give SSRIs? If the female is having a contraindications with the CHC, then you can move on to SSRIs. And if the female having more depression, angry outbursts, then you can start with the low dose SSRIs. Then the second line, you are going to give estradiol patches, micronized progesterone, or levonorgestrel IUS based on the preferences of the female, what she wants. Then you can move on to with that one. If the SSRIs she has already been taking, it's not working for her, then you can increase the dose if that SSRI is not working for her. Then third line, GnRH, add back HRT. So you have to go step by step. First line, second line, third line, and then after that, if everything you have already given and nothing is working out so far, then you can give surgical treatment and HRT. So don't start from HRT, start from combined hormonal contraceptives. Now coming to the premenstrual dysphoric syndrome, when we are going to say this is premenstrual dysphoric syndrome, when they have more severe symptoms and impairment of functioning. Now this person cannot go to office, this person doesn't even can work because have a lot of headache, depression, these symptoms, and have severe symptoms. Now whenever she has this symptom, she is unable to do anything. So all of these symptoms, what are those symptoms? Irritability, depressed mood, breast pain, and abdominal bloating. So all of these symptoms are same, but the symptoms are, the intensity is so severe that it's impacting their functioning. In that, you have to rule out asking them what if this is impacting their life. In this, they will definitely tell you that they have already been impacted in their life. Now they are coming to you. So at least 5 of the following in the 11 symptoms. So these are the 11 symptoms, and these 5 of them should be there, or with at least one of the first 4. So what are the one of the first 4 are depressed, anxiety, affective instability, anger or irritability, and decreased interest. So from these first 4, there should be at least one, as one psyche symptom should be there, and along with lethargy, difficulty in concentrating, change in appetite, hyperinsomnia, insomnia, overwhelmed physical. So this can be presented along with this. So there should be one, as you can see, one psyche and along with one somatic symptom, but the symptoms are so severe that is affecting their daily life. Symptoms can be significant distress or interfere with the social and occupational functioning, and symptoms may present during the week prior to the menses and resolve within few days. So it is eventually along with the menstrual cycle, and may be superimposed on other psychiatric disorders. So make sure you rule out depression, make sure you rule out anxiety, irritability, anger issues. If she is having a mood symptoms like mania, all of these you have to learn. Then on after that, you are going to say that yes, this is premenstrual dysphoric syndrome, and the treatment is just the same. You are going to start with exercise, CBT. So always when you are writing this treatment, always start from non-invasive, where you're going to talk about the lifestyle modification. Then after lifestyle modification, if she needs, because on the basis of their daily life impaction, you are going to start the treatment. Here we don't start the treatment right away, just like in our back countries. Here in this like in Canada, usually we start the treatment after all the things, like all the lifestyle modification, vitamin B6, this and that have already been given. Then if needed, then you are going to start with any medication, and you have to counsel about all of the medications. When you are talking about medications, always talk about their side effects with the patient, so they are aware of all the impact that can be happening because of this medication. So they don't come to you after, oh, you give me this medication and now I'm having this problem. So you have to talk about contraindications, the medication side effects. This comes in basically ethics. So now talking about amenorrhea. Amenorrhea is basically, you have to remember all of these side, like, symptoms. So it is very important. At the same time, if you remember from this side, table, it will be very easy for you to remember this one. So let's start from this one. as a female is coming to you, she is having amenorrhea. First of all, you have to rule out primary or this is a secondary. Like primary, the female does not never have any symptoms, like, she never had menses. Now moving on to secondary, she had menses. Now at this point she is not having menses. Now if she is coming for the secondary, we always start from beta hcg, always, because secondary, the most important cause is pregnancy, so we have to rule out beta hcg. If it's negative, then we can think of prolactin, but most importantly, we start from here and then goes there. I know it is written like from there to here, but we start from here to there. So kindly see what we are going to do next. Since a patient is coming to you with a secondary amenorrhea, we don't directly jump to prolactin until unless the female is having a breast discharge or like headaches. Then we start thinking of prolactin. Otherwise, we start with what? With which? LH, FSH, progesterone, then we progesterone challenge, then we move on to the prolactin when we are thinking about that. So we are going to start from here. If we are going to do, this is basically LH and FSH, we are going to see if it's high or it's low. On the basis of that, we will rule out if it's PCOS, if it's a HPO axis, MRI, hypothalamus and pituitary. Now once we rule out LHFS, there is nothing going on here. This is normal, everything pretty okay. Then we are going to moving on to the next one, which is progesterone challenge. We give that and then see if there is a withdrawal bleed or if there is a no withdrawal bleed. Then on the basis of that, we will rule out if there is a primary ovarian insufficiency, uterine defect, Asherman syndrome or HPO axis. Now we already did that and it is totally normal. Now we are going to move on to the next level, which is basically prolactin. So we are going to check out the prolactin. The female is having a headaches, breast discharge. So then we move on. As you can see, we start from here, then moving on to there. We never start from prolactin, then progesterone and LHFSH. We start from beta HCG, we do LHFSH, then we do progesterone, and then we do prolactin. This is normal approach because these female having PCOS is more common than having prolactinoma. Okay, so you need to see what kind of symptoms. On the basis of the symptoms, the whole investigation is changed as well. Now starting from the primary is basically we are going to see the secondary characters. So on the basis of the secondary characters, that will help us if it's a genetic problem, it's a not a genetic problem. Since the female have already developed all the sexual characters, then we are going to do next is basically karyotyping. Yes, the sexual characteristics are there. Then we are going to check for the karyotyping, that if it's a perforated hymen, transverse septum, or it's a cervical agenesis, all of those things. If it's a XY, then it's androgen insensitivity syndrome. Then if it's a secondary sexual characteristics does not develop, then we can think of maybe FSH and LH, the hormone that is making the breast development, pubic hair, all those axillary hairs, those things are not developing because of some particular hormone level. So LH and FSH, it's high or it's low. If it's high, then it's hypergonadotropin. If it's low, then it's a hypogonadotropin. So on the basis of that, you will see if it's a primary one, it's a secondary one. So you have to know the approach and how you are going to do the further test. If you start from which is not necessary, it means you are using the government resources for unnecessary purpose and you will be considered as a bad doctor. So that's most of the people why fail their exam. This is basically why, because we don't know how to approach the case when they are giving you particular symptoms. They want you to write down the particular investigations. We cannot write down every investigation in every case. Then investigation, everything as already explained here. So this is how we are going to approach. As you can see it, beta HCG, then we are going to do this particular hormone level one by one, FSH, LH, androgen, estrogen, then moving on to the prolactin and TSH and all of those things. Then karyotyping and ultrasound. So now moving on to the sidebar, this is one of the important thing. I want to discuss it with you because this is important. So most common cause of the primary amenorrhea, if the female is coming to you and she had never got menses and this is her first time and everything, right? So you have to rule out which of the first thing, Mullerian agenesis, which is the second thing. You have to rule out that Turner syndrome, obviously on the basis of the characteristics, if she has breast or not, or all of those things. Then the functional hypothalamic amenorrhea, like she might be having anorexia nervosa, she might be having a quick strict diet. So you have to rule out, along with this, if a female is having amenorrhea, along with that you have to rule out if she is having a swear level of exercise, she is like thin, BMI. So you have to rule out all of those conditions. So a lot of female in the primary amenorrhea always like have some psyche issues behind their back. So you have to rule out all of those hypothalamic amenorrhea thing in the primary amenorrhea thing. Then Functional hypothalamic amenorrhea is the most common cause of the secondary amenorrhea. Definitely the female is having, so you have to rule out, since she's a female 24, 25, and she never get, sexually active, then obviously you cannot think of pregnancy. Then you have to think of something else. They might give you in the scenario that she was a ballet dancer, she's a athlete. So on the basis of that, you have to rule out secondary amenorrhea cause, which is basically functional hypothalamic amenorrhea. So as you can see, functional hypothalamic amenorrhea is the cause of the primary and secondary as well. So it's basically covering both of them. So you have to rule out this exercise, their diet. So these things here, weight loss, excessive exercise, and systemic disease. So this comes in that one. So you have to rule out this particularly in every female, not just primary, not secondary, in all of the female. As you can see, it's most common in both of them. Then prolactinoma comes with the galactorrhea, visual changes, and then headache. So management depends on the cause, which we have already find out in investigations or history or physical examination. So whenever they're talking about management, always start with the history, physical examination, investigation, and then treatment. Don't just write on the treatment directly, because management covers everything. So first amenorrhea, androgen insensitivity syndrome, since an androgen problem. So you are going to start with the gonadal resection, psychological counseling. So first thing first, you are going to start with the counseling, because gonadal resection or neovagina dilation, this is what the person will tell that she wants it or not. Okay, so starting from the psychological counseling, you have to tell what the problem is going on, so she can assure what is going on, if her body is normal or not. As you can see, these days these kind of things is going on very commonly. So you have to start from the psychological counseling, making the patient reassure that this is totally okay, this is totally normal. Then what she decide, on the basis of that you will proceed further. So now you are going to start from the psychological counseling, even in this one, and in the Mullerian agenesis. So you are going to start. So one thing that is asked in the Mullerian agenesis, what other disease that can be linked with the Mullerian agenesis? So there's a kidney problem, obviously a urinary system. So diagnostic study to confirm the urinary system. If they ask one thing which you want to rule out the Mullerian agenesis, should be the kidney system, like a nephrotic, not actually nephrotic, actually urinary system. Why the urinary system? Because in the Mullerian agenesis, since the all the system is not fully formed, so the urine system might not be formed as well. So you have to confirm. This is also called like screening. If you want to do screening in the Mullerian agenesis, what you should be ruling out is other normal urinary system. So this is one thing that you shouldn't be missing in the Mullerian agenesis. Then talking about the imperforated hymen, vaginal septum, cervical dysgenesis, all you have to do is surgical management. So first thing first, psychological counseling. If the female or the person wants the treatment or the surgical management, then you are going to proceed further. As you can see, whatever they decide, you are going to proceed further with that. So primary amenorrhea, secondary amenorrhea, then secondary amenorrhea. Then obviously on the basis of the what the thing is, you are going to start HPOX says, identify the underlying cause, maybe weight, maybe exercise, whatsoever it is. You are going to start with a counseling here again. Then combined OCP to rule out, to decrease the osteoporosis, maintain normal vagina, and then breast development. Hyperprolactinoma, since there is a prolactinoma, you have to see if the patient is having headaches and all of these things. Then on the basis of that, you are going to do MRI, CT scan. Don't just directly jump to MRI, CT scan. You can do prolactin level. You can take a history of the headaches. You can take a history of breast discharge. Then you can think that if the person needs CT scan or MRI, then you are going to do CT scan and MRI. Don't just directly route down CT and MRI. Then if no demonstrable lesions by MRI, as you already done MRI, you cannot find out anything, then you can actually do with bromocriptine. Start with a combined OCPs if no fertility desired. If the female wants to get pregnant, if they said this, a female wants to get pregnant, then you can start with the bromocriptine. Otherwise, you can start with OCPs. In the pregnant female or in the fertility issue, you cannot start with the OCPs. Then demonstrable lesions, then you are going to start with the surgical management. So demonstrable lesion means in MRI, there is a prolactinoma that is being identified. So that's why obviously you are going to start with the surgical treatment. PCOS, this is another table that is going to be covered in PCOS. Premature ovarian failure. So you have to rule out screen for diabetes. So this screening is very, very important, because in these particular diseases, you have to screen the other conditions. So in the premature ovarian failure, you are going to rule out which conditions? Diabetes, hypothyroid, hypoparathyroid, or hypocortisolism. So as I already mentioned, in the thyroid, there is so many diseases that are linked with thyroid. So always rule out if there is any condition that you have to rule out along with this particular condition. that is being given here. So they can ask, if you want to rule out one other condition, what would that be? So you have to know which are those conditions. Hormonal therapy, you are going to start with the estrogen and progesterone. Uterine defect evaluation with the hydrosalpingography and sonography if there is a defect. So you can see from there. If there is a Escherman, you are going to hysteroscopy to do the synecdoche. Even in this one, first thing you have to start with the reassurance, telling them what there is going on, psychological counseling, then you are going to move on. Most of the people with Escherman syndrome comes with the infertility. So, talking about the infertility first. Secondly, pneumonia is pregnancy until proven otherwise. If there is no pregnancy, then you have to think of hypothalamic. So, okay, endometriosis. Endometriosis is the presence of the endometrial glands outside of the uterine cavity. This is a chronic condition resolving only with the menopause. So the endometriosis, it is basically one of the very, very common condition that can present in the family practice as well. Then from there, if the patient is needed to move on to gynecologist, the family physician is going to decide that the patient is needed to be seen by a gynecologist or he can treat it. So you have to see, it is basically not fully understood. So the mechanism you can see from there. So differential diagnosis is important, because if your scenario is given with the endometriosis symptoms and they ask you write on differential diagnosis, because obviously on this history you cannot just make the diagnosis, you have to write on the differential diagnosis. So you need to know at least 3 or 4 of all of the disease, whatever you are reading. Make sure you know the differential diagnosis of 2, 3, 4, 5, any number you can remember. So chronic PID, acute salpingitis, I'm not talking about just the gynae. I'm talking about overall whatsoever disease you are reading. Then hemorrhagic corpus luteum, benign ovarian neoplasm, and then ectopic pregnancy. 4 Ds of the dysmenorrhea, dysmenorrhea, dyspareunia, dyschexia, and dysuria, wherever the implantation is. Talking about the family history. So if they are giving you what is the one thing that you have to look or ask in the history in the patient of dysmenorrhea, that is basically family history. Why? Because 7 to 10 times, if the family person has this disease, it will eventually be present in this person as well. So ruling about the family history is important, because this is 7 to 10 times increased risk. Then obstructive anomalies, nulliparity, and the age more than 25 years. So as you can see, this is different from the what was the different one? Adenomyosis. It has like a lot of already surgeries and these things. So but in this one, it is basically nulliparity. Then sites of the occurrence. So where can it can be? So most of the common site is basically ovaries, where it is basically 60%. Then it can present in the 3 forms. Clinical features is divided into 1, 2, and 3. So it can present in 3 forms, either with the pain, either with the infertility, either with the mass. So starting from the pain is basically menstrual symptom, like in the menstrual phase where the patient is having this menstrual cycle. Now in the menstrual cycle, because of the growth and bleeding, so patient is having a lot of pain, sacral back pain with the menses, and pain will become chronic, worsening premenstrually, and the deep dyspareunia. So it will present with the menstrual symptom. Then along with this, bowel and the bladder symptoms. What are the bowel and the bladder symptoms? Frequency, dysuria, hematuria. So pain can be along with the menstrual, can be along with the bowel and the bladder, like urine and passing the stools. So it can has pain along with it. Then starting from the infertility, has like 10 to 40% with endometriosis will be infertile. So can be present with the infertility directly. Then 15 to 30% that are infertile will have endometriosis. So it can come both ways, either with infertility, either with endometriosis. Then mass, ovarian mass can be present, any of the above, or maybe asymptomatic. So either these 3 can be present, like pain, infertility, and then with the mass. Starting with the investigation, definitive can be made on the visualization. So how you are going to do the visualization? Laparoscopy. So laparoscopy is the gold standard to make the diagnosis. Then you can see, what you can see on the laparoscopy is basically mulberry spots, chocolate cyst, powder burn, and then white lesions and peritoneal pockets. And CA125 is going to rule out, but it's not used as a diagnostic. So just the only diagnosis is laparoscopy. As it says, suggestive to the history. History itself can make the diagnosis of endometriosis. Pelvic pain that is not primary dysmenorrhea should be considered endometriosis until proven otherwise. Until you don't prove it wrong, it is basically endometriosis. So if the patient is having a pelvic pain and this is not a primary dysmenorrhea, you have to think of endometriosis until you prove it wrong with some other diagnosis. Then suspected endometriosis, first line is CHC. So you are going to start with CHC. Then progesterone alone. Since it's the treatment failure, now you are going to give the female two options. Either she can do laparoscopy, either she wants to go with the GnRH. Totally up to her. If she wants to start the treatment, then you can start with GnRH. You cannot go with the laparoscopy. If she wants, no, doctor, the patient that is whatever the medications is not working. Now I want some particular, investigation. Then you proceed on with the laparoscopy. Reconsider additional testing, non-gynecological referrals if the patient all the medications is not working, chronic pain management, and the multidisciplinary approach. So on the basis of that, as the surgical confirmation of the disease is not required, so prior to the starting medical management, so you don't need to start with the surgical confirmation. You are not going to start with the laparoscopy. Then medication is basically NSAID since a lot of pain, cyclical OCPs, progesterone, Mirena IUS, GnRH agonist as the second line, and then danazole. As you can see, you have to write down GnRH analog with add back therapy. Don't write just GnRH analog, because in the GnRH analog, it's not a complete answer. Since you are going to start GnRH analog along with the add back therapy like progesterone and estrogen, so you have to write down GnRH analog with the add back therapy. Then danazole, you have to know the side effects. Then surgical treatment, laparoscopy, electrocautery and laparotomy, then ablation and the resection of the implants, lysis of adhesion, and ovarian cystectomy, hysterectomy, and then bilateral salpingo-oophorectomy who doesn't want to continue their fertility. Best to become pregnant after the resection of the implants. The patient is not planning to become pregnant, then you can start with the suppress ovulation right after the resection of the implant. So that's about it. So we covered pretty much it. If anybody has any question.